This is a presentation on optical illusions in clinical research. These are instances where you look at the results of a clinical study, and initially they seem to be saying one thing, but when you really examine it carefully and think through it, it turns out that they're saying something quite different. In fact, in some instances, opposite of what they initially seem to be saying. Now, let me start first with examples of what I call everyday cognitive optical illusions to give you a flavor for what I'm talking about. So here's the first one. First one is that you're in a foot race and you pass the person in second place. What place are you in? Now think of the answer. Hold it in your mind. The second is the following. If there's a pencil and an eraser and together combined they cost $1.10, and the pencil costs $1 more than the eraser, then how much does the eraser cost? Think of the answer, hold it in your head. Now, I'll show you the right answer, which is that you're in second place if you pass the person in second place, because you haven't passed the person in first place. Most people say you're in first place. And the eraser cost 5 cents, not 10 cents, which is what most people say, because that's how our brain works. And the reason is that primate brains have evolved to process everyday data, anecdotal data, and it's quite good at that. And the brain tends to take mental shortcuts called or heuristics, and that's fine in 90% of the cases, although as I've just shown you, it can be wrong even in everyday life. However, our brains are not well designed to process and interpret statistical data, aggregate statistical data. It does a very poor job of that, actually. And because of that, you can often end up misinterpreting clinical results. So let me talk about the first optical illusion, or regression to the mean. I sometimes call this the Lake Wobegon illusion because, as you know, you probably know, Lake Wobegon is where all the women are beautiful, men are handsome, and every child is above average. And this is about averages. So let's say there's a drug that looks very promising, and that's being developed for depression. And it goes into phase 2, and unfortunately, as you can see on this slide, it fails to meet the primary endpoint. Doesn't improve the symptoms at all, no signal. Yellow is before drug, and light color is after the drug. Now, you're about to bite off the drug, but one of the preclinical scientists come up to you and say, you know, I told everyone that the study was poorly designed. All the preclinical data demonstrates very clearly that the drug will only be effective if the patients have severe disease. And that's the way it should have been done. So you say, okay, well, let's look at what happened to the patients who were the most severe. And lo and behold, if you look at only the patients who had severe disease, then you have a p of less than 0.001. Very clear pre and post difference. So get very excited and you advance the drug into phase 3, and it fails. Now, why did it fail? The reason is this. In depression, like psoriasis or other waxing and waning diseases, patients tend to get better and worse spontaneously. They have good days and bad. Now, if you take patients who are having a particularly worse day than usual, and then you take another measurement later on, they will tend to have less severe disease because they get better and worse. And you take them on their bad day, the next time you take a measurement, they'll probably be doing better, just from the natural course of the disease. So if you had taken the phase 2 study and looked at the most severe patients who received placebo, you would have seen in that group that they appear to have improved as well. But in fact, it's an illusion, because in a waxing and waning disease, or when you have an endpoint that has some variability or significant variability associated with the measurement, you will have regression to the mean if you take the patients who are at the extremes. So what can you do about this? Well, you should never compare just a subgroup from one of the dose groups against anything other than the same subgroup from another arm. And you can also stratify by severity if you really think, or another factor, if you really think that that particular factor is going to make a difference in terms of how the patients respond. And that can protect against regression to the mean, as well as some of the other illusions that I'll talk about a little later on. Now, I will say regression to the mean is seen across studies as well. So, for example, it's not uncommon that a small phase 2 study will show spectacular results, and then the compound will fail in phase 3 or be less impressive. And this is because when you have a set of phase 2 studies, some of them are going to look better than, some of the drugs are going to look better than they actually are, and some will look worse than they actually are. And more spectacular the result, more likely it is that the phase 3 will not replicate that spectacular success. This is particularly the case when the phase 2 study is small. Now, the second illusion is survivor bias. So let's say that there's a new anticoagulant being developed for myocardial infarctions, or MIs, and you anticipate that it's going to reduce the damage to the heart after MIs, and that will, of course, mean there will be fewer deaths. Nowadays, mortality from MIs is pretty low, so like any good clinical trialist, you realize that you need to have more events than just death, because the sample size will be very, very high when you're talking about death, the mortality rate of 3 or 4%. So you say, well, the two of the most common sort of severe sequelae after MI is death and congestive heart failure. So in order to power the study adequately without having tens of thousands of patients, you decide to pick congestive heart failure rather than MI as the primary endpoint, because that will make your sample size smaller. So you do the study, and much to your shock, you find that the rate of CHF is actually increased. So then you ask yourself, boy, what's going on? Is the drug not effective? Does it have no biological effect? But then you take a look at this data, the combined rate of heart failure and death. And as you can see here, what happened is that the drug did work, and it was quite effective in preventing death. But what happened is those patients who had large MIs, who would have normally died, did not die because of the drug. But they did have quite a bit of damage to their heart, and therefore they ended up with heart failure. So if you were to look at the combined rate of death plus CHF, you would have seen that the drug was effective. Now this is similar to the World War II bomber analogy that is sometimes used as a teaching point. In World War II, there were many British bombers that were lost in raids over Germany, and somebody came up with the bright idea of examining the planes for where the holes were. And they said, well, let's patch and reinforce these areas because that's where the planes are getting hit. And they did that, and it did not help with the losses at all. And the reason is that the holes were good indications of which areas in the plane were non-vital. So it didn't matter if they were hit. The areas where the holes were never found, those were the right areas to reinforce because those represented areas where if the plane got hit, the damage would be so tremendous that the planes would go down. So this illustrates that it's really important when you're looking at clinical outcomes to understand, are those outcomes indications that the drug is working, or are they paradoxical indications that the drug is actually providing a benefit? And it's not always easy to tell the difference between the two. So what can you do about this? What can you do about the survivor bias? Well, you should always make sure that when you're designing endpoints, that you look comprehensively across the disease and make sure that you're including all the right endpoints and that you're not making the mistake of just shifting some of the events from one type of an endpoint to another. And you should also make sure that if you need to capture sort of a broader range of endpoints, that you consider using composite endpoints, which are endpoints made up of more than one outcome. So for example, MACE, major adverse cardiac event outcome, can include events such as stroke, MI, and other cardiovascular outcomes. Now, the third illusion is the difference between groups and individuals. In clinical research, we're used to looking at aggregate data and aggregate statistics like the mean or standard deviation. And sometimes we forget that the group represents some information about the individuals, but it's actually the group statistics are different from their individual statistics. And an example would be the following. Let's say you have a drug that you're developing to treat seizures, and you really want this drug to have a very gradual dose-response curve. You want it to have a kind of wide therapeutic index. And the data to date suggests that this drug does have a wide therapeutic index. So what you do is do a phase 2, and it's great. You take the aggregate data from all the patients and you sort of graph the dose-response curve, and the dose-response curve seems quite nice and wide, or wider compared to the other drugs that are available. Now, the problem though is illustrated on this slide, which is that just because the dose response is wide, gradual for the group as a whole, doesn't mean that it's wide for each person in that group. In fact, the dose response may be very, very steep, but because each individual patient has slightly different dose response curve, when you average all the dose responses, you may get something that looks gradual when in fact the curve is quite steep for each individual. The fourth type of cognitive optical illusion is subgroup analyses. And subgroup analyses are done very, very commonly, but really without understanding or appreciating how treacherous they can be. So the three main types of issues you can run into with subgroup analyses, and there are many, but the three main ones are using a dependent variable, using a completer analysis, and using a responder analysis. Now, what do I mean by dependent variable? Well, when you look at the different types of characteristics that you can divide up the group by, there are those variables that are fixed at the beginning of the study. They don't change in the course of the study. These are things like sex or age. The patients come in with these factors and they don't change. Doing subgroup analyses based on these divisions are much less risky than using variables that can change or that arise in the course of the study, such as compliance or dropouts or PK parameters. For example, let's say you're developing a drug for some GI um, indication, and when you look at the primary endpoint, there's no signal. Placebo group, low dose group, high dose group, before and after the drug, really the symptom severity is not really different. But one of the formulation experts comes up to you and says, look, the formulation wasn't great, and I really think there could have been a problem with the absorption. So obviously, if the drug doesn't get absorbed, it's not going to work. So why don't we look at the correlation between the plasma level of the drug and the efficacy? And you take a look, and lo and behold, there's a great correlation. In patients who had the highest plasma level of the drug, they improve the most. And you say, wow, that's great. No wonder this, we didn't hit the primary endpoint the other way because the drug's not getting absorbed. So you advance into phase 3 and study's negative. So what happened? Well, you have to remember that in many studies, patients are less or more sick. And in this case, the patients who were the least sick had the best mucosa in their gut and were able to absorb the drug best. Therefore, they had the highest levels of the drug. And because they were less sick to begin with, they also did the best in terms of outcome. So this is what some people call true, and unrelated. Yes, it's true the patients had higher levels of drug. And yes, it's true these patients did better, but there is not a causal effect between the drug and the outcome. Both the drug level and the outcome are influenced instead by a third factor. That factor is, of course, how severe was their disease to begin with. And this is an example of why if you take a variable that occurs in the middle of the study, such as plasma level of the drug, and you try to correlate that with the outcome, that can really lead you astray. So the next example of subgroup analysis that can lead you wrong is completer analysis. So in this example, let's say you're developing a drug for arthritis, and it seems to be very, very effective, at least in some patients. But it has a side effect of severe itching. And when you do the phase 2 study, the itching is so bad that 30% of the patients drop out. So given that the dropout rate is so high, you decide to do the analysis only using completers. So you do a completer analysis, which means that you only look at the patients who actually completed the study, got enough courses of doses of the drug, and in the completer analysis, looks reasonably good, P of 0.08, and there seems to be a strong trend towards benefit. Now, you say, well, that's pretty good, but it doesn't quite meet the statistical significance. And then one of the people on the team says, well, I was talking to a statistician the other day, and he said you always want to use a continuous endpoint, which is percent benefit or some score, rather than a binary or dichotomous endpoint. The person responded yes or no. So you say, oh, that's very interesting. And then somebody else says that, well, the drug is only going to work in those patients who are going to work. Why don't we just look at the patients in whom the drug works? There's some pharmacogenomic reason why some patients are going to respond and some patients not. So let's just look at the responders. And you say, okay, well, let's take a look. And you find that, boy, if you look at patients who responded, only at the patients who responded, then this drug looks great. P of 0.001, and it is going to be a winner. So you do the phase 3 study, and it fails. So what happened here? Well, whenever you're examining the data based on some subgroup rather than all the patients who are randomized, then you have the risk of introducing a bias. And in this case, let's say that the patients who were the most likely to have the side effect of itching were also patients who happened to have the most severe disease. So the patients who dropped out are the patients who had the most severe disease to begin with, and therefore, when you look at the patients who completed the study, what you're left with is a sample that is missing those severe scores from the patients who dropped out. Now, in this slide, it's a little bit more intuitive why the results are as they are. So let's say that in both the placebo and the active group, similar number of patients responded, 26, 27. However, there were no dropouts in the placebo group, but the patients who had the most severe disease dropped out in the active group. So the denominator is 82 for the placebo and 61 for the active. So even though the exact same number of patients responded, the denominator is larger in the placebo group. So the response rate looks artificially higher than it actually is. Now, this bias is exacerbated when you're looking only at the responders, because recall that in the active group, the most severe patients dropped out, whereas in the placebo group, they didn't. So some of the most severe patients in the placebo group may be included in the analysis. And because they have the most severe disease to start off with, when you take the combined pain scores from each of the groups, you're exacerbating the bias. So this is a little bit difficult illusion to get your mind around. So let me give you an analogy. Let's say that you want to find out who is richer, people in United States or people in Chile. Now, you don't have access to the income data, but you happen to have a good friend who works for Mercedes, and he says, look, I can get you the average income of our customers. So you say, oh, that's great. So you look at the average income of Mercedes buyers in United States and compare them to the average income of Mercedes buyers in Chile. And you find that, boy, that number is higher in Chile. Now, of course, this is because the average buyer in Chile, which is a very small portion of the population, is richer than the average buyer in the United States, because the income disparity is so much higher in Chile that the rich there are very, very rich, but the poor are very poor. So when you look at the comparison between income of one subgroup versus another subgroup, but those subgroups are different, you can be led to erroneous conclusions. And whenever you're doing responder analysis or a completer analysis, you run the risk that you're comparing apples to oranges. So as your statistician will tell you, you always want to try to do intent to treat analysis. And going back to my earlier point, if you must do a subgroup analysis, try to do them based on categories that are fixed at the beginning of the study, rather than something that happens in the course of the study. Now, let me talk about what I call puzzling proportions. You have 4 statements here, all about mortality and survival. Drug reduces mortality by 90%, drug reduces mortality by 9%, it improves survival from 90 to 99%. Well, these are all equivalent statements. And it's really important when looking at clinical trial results to think in proportions rather than thinking linearly. So, and to think about the fact that 1% mortality is same as 99% survival, 10% mortality is same as 90% survival. So in fact, going from 1% to 10% is same as going from 90 to 99%. And that's not intuitive. Most people say, oh, going from 1% to 10% is not the same as going from 90 to 99%. 90 to 99 seems much more similar than 1% to 10%, but in fact, they're exactly the same. Also, you have to remember that the difference between 0 and 90% is actually comparable to the difference between 90 and 99%. And this is because there's tenfold difference between 10% and 100%, and tenfold difference between 1% to 10%. So for example, let's say you buy a weed killer for your lawn, and one package says 99% effective, and another package says 99.9% effective. You may think that they're similar efficacy, but in fact, if you use one of them, you might have 10 dandelions. If you use the other one, you may have 100 dandelions, because that 0.9% difference is actually tenfold difference. So we should keep in mind the different types of different ways of looking at the data, absolute difference, relative difference, and odds ratios, which are illustrated on this slide. And when you're looking at clinical trial data, always remember to think in terms of proportions. Now, the sixth illusion is post-hoc analysis. Some statisticians like to say that if you torture the data long enough, it'll confess to just about anything, meaning that if you look hard enough, you can find what looks to be a positive result that is almost always spurious. So here's an example. Let's say you're doing a study of pulmonary fibrosis, and the initial results are negative. But it turns out that when you look at some of the other endpoints, for example, mortality, that there seems to be a signal. In fact, for mortality, the results seem to be outstanding. So then you do a phase 3 study using mortality as an endpoint, and the trial fails. And this is because whenever you have a study, if you do sufficient number of analysis, post-hoc analysis, you will almost always be able to find some result that looks spectacular and very compelling biologically. It makes a lot of sense. But in almost every case, those results are spurious. In fact, you can link positive results to just about anything if you try hard enough. The famous instance being the statisticians in the Gusto study who demonstrated that your astrological sign, whether you're Virgo or some other sign, is very strongly predictive of your survival after an MI. Obviously, this is patently spurious, but in other cases, the correlation is not quite so obviously false. The seventh illusion are surrogates. And there is a famous study called the CAST study. And this is a study of patients who had MIs, and it was noted that the patients who had the most number of these irregular ventricular contractions, PVCs, were at the highest risk of death, sudden death after an MI. So several drugs were developed that did a beautiful job of cleaning up these PVCs and were thought to reduce mortality post-MI. Now, some physicians wanted to test this and conduct a study where some patients would be given antiarrhythmics and others given placebo. And this is very controversial because really it seemed unethical to have a placebo arm in this study. But after much sort of debate, they started the study and they had a DSMB to monitor the study very carefully so that as soon as it became clear that the antiarrhythmics were saving lives, the study could be stopped. And in fact, the study was stopped early, but because patients on the antiarrhythmic drug were experiencing much higher mortality than the patients on placebo. And this illustrates an important point that just because a surrogate, a non-clinical endpoint, appears to be compellingly improved by a drug does not mean that it's going to improve the clinical outcome. Another example, not as dramatic, but also illustrative was a study that was done with TNF inhibitors, where there's very good data suggesting that when you look at CHF patients and measure their TNF levels, the patients with the highest TNF levels are at the highest risk of dying. So a study was conducted to give these patients TNF blockers, TNF inhibitors, and much to everyone's surprise, these drugs increased mortality. So this is an example where a biomarker or some biological phenomena may be associated with the disease, and it appears that they may be contributing to the sequelae of the disease, but when in fact they may actually be a body's response to the disease and may actually be beneficial. Now, the eighth illusion are statistical flukes. So let's say you have a new drug that's being developed for wound healing, and the phase 2 results are very convincing, p of 0.002, but one of the sites had very strange results in that the placebo is doing much better than the active, and an investigation is launched to see what the site's doing wrong, and it turns out that actually, from a statistical standpoint, if you have multiple sites, then one or more sites will show not only inconsistent results, but actually opposite results. So in this slide, you can see that if you have 8 sites, for example, there's a 75% chance that at least one of the sites will show statistically significant effect opposite to what the overall study shows. And then part 2 of this illusion is that you take the drug into phase 3, but because you're worried about the fluke in that one site, you decide to do 4 phase 3 studies instead of 2. And you find that even though all 4 studies were identical, 3 of the studies meet the primary endpoint, but the 4th one misses it. And people are very puzzled why that would be the case. Well, even if you have an active drug, and even if you design a study well, if you have 90% power or something less than 100% power, if you do enough studies, if you do the study enough times, then sooner or later one of the studies will fail. So for example, if you have 90% power and you do 5 studies, the likelihood that all 5 studies will meet the primary endpoint, even if your drug is active, is only about 60%. If you're powered at 80%, the likelihood that all 5 studies will hit statistical significance, even if the drug is effective, is only 1 in 5. The 9th illusion is the safety shuffle. So let's say you have a drug that's being developed for refractory seizures, but you're concerned about 2 potential side effects. One is arrhythmias, and the other is duodenal ulcers. So you do the phase 3 study, and you look at the safety data very, very carefully, and much to your relief, you see, there really doesn't seem to be a signal, no real difference between placebo and active. Now, if you look at the data a little bit closely, then you may find that there may be a signal that you missed, because let's say instead of just looking at patients who had arrhythmias, you look at sudden death, palpitation, syncope, other terms or side effects which may be manifestation of arrhythmia. Then you may find that actually for duodenal ulcers, you can do similar analysis. And you have to sort of zoom in and out and make sure that you're not missing something because you zoomed in too closely or zoomed out too much. So if you look at, for example, all abdominal pain, you may find no signal. Or if you looked at nausea or gastroenteritis or anemia, you may not find anything. But if you were to look at acute abdominal pain, then you may find that there is a signal. So safety data, because safety data is not pre-specified, you have to make sure that you're splitting the terms appropriately, or else you may miss a signal. P-values. So let's say there are 2 companies that are in neck and neck race. They're developing a therapy that that is meant to treat some congenital storage disease, then their drugs are very similar. But when the results came out, one company says their study hit a p-value of 0.0001, another one says they hit a p-value of 0.04. Does this mean that one company's drug is much better than the other? Well, that could be true, but equally plausible is that the drugs were actually very similar and worked with similar efficacy, but one company just had a much larger study than the other. And this is a really important point, that p-value reflects two things. One is how well the drug works, but the other is how large the study is. So impressive p-values in and of themselves don't necessarily mean that the drugs work any better. The other thing to remember about p-values is that the bar for efficacy is p of 0.05, and that's an arbitrary number that has been selected by statisticians and clinicians. The bar for safety is quite different, because you always want to be more cautious about safety signals than efficacy signals. So, for example, it would not be reasonable to say, look, I am going out of the house, but I'm not going to lock the door because I'm only 80% sure that I'm going to be robbed. Or to say, I'm not going to buy fire insurance because I'm only 92% sure that my house is going to burn down. The strength of data that will make you act in terms of safety, it should be very different from the standard that compels you to act from an efficacy viewpoint. The other thing to remember is that when you look at multiple endpoints in a study, there needs to be adjustments for the fact that you're looking at multiple endpoints. So if you're looking at 2, then p should be 0.025, sometimes less. And also, when you do post hoc analysis, p-values there are what's called nominal, which means that it's hypothetical. This would have been the p-value had that been the primary endpoint, but it wasn't, so it doesn't count. In sort of like saying, well, this would have been a world record if this had been the Olympic competition, but it wasn't for real, so it doesn't count. So thank you very much. That's the end of my lecture, and I hope you found this interesting and helpful.